Hi, we are looking at the respiratory system today. Learning objectives you see here, we're going to look at the internal and external gas exchange systems. We're going to talk about the structures of the respiratory tract. We're going to describe the mechanism of breathing, including the roles of the diaphragm and the phrenic nerve in helping us to breathe. We're going to talk about how oxygen and carbon dioxide are carried through the blood, both oxygen to the cells and carbon dioxide carried away for expulsion from our body. We're going to look at different word parts, of course. It's medical terminology. We're going to talk about some disorders associated with the respiratory system. We're going to talk about a couple of pathogens that can infect the respiratory system. And you're going to look primarily at abbreviations. We'll look at them very, very quickly, just at one or two of them, and then you'll be looking at the remainder of them to just confirm that you see that they're there and how you use them with reference to the respiratory system. This picture in your textbook was a nice illustration of the major parts of the respiratory system. I will go through them very, very quickly and focusing on the things that we need to worry about. Not that we don't worry about all of them, but there's only so much we can do in midterm. So the frontal sinus, not surprisingly, if you know what a sinus is, I'm sure most people do, and a sinus is really sort of an air-filled cavity. And so the frontal sinus is an air-filled cavity in the forehead. Helps a lot with one of the main functions of the respiratory system, which is filtration, but also with your voice. The nasal cavity is another cavity. It's behind the nose, and you can see it here. A little space behind the nose that filters air, warms it up, helps to humidify it as it comes in so you don't get too dry. The oral cavity is exactly what it sounds. It's the mouth. It's a way that you can breathe. You can breathe through your nose or your mouth. Your nose, your nostrils are called the nares, N-A-R-E-S, nares. They're not labeled here. The epiglottis is that little flap that's hanging in your throat when you look in the mirror. If you open up and the doctor says, they're looking down past your epiglottis. Let's see, the larynx. The larynx we're talking about, that's where the voice box is. So it's really right here, and it's in the entire area called the laryngopharynx right here, the laryngopharynx. And that's really talking about the lower section of the pharynx. We haven't gone through it, the whole thing yet. So the pharynx has three sections right here. We have the nasopharynx, which is behind the nasal cavity, the oropharynx, which is the area behind the mouth, and then the laryngopharynx, which is behind the lowest part of the pharynx. So the laryngopharynx is the lowest part. And within the laryngopharynx is the larynx, and the larynx is the voice box. Next to that, we see the esophagus as well. We will see here where the larynx is. It's a tube right here. The trachea is a tube. It's kind of a, we call it, commonly we talk about the windpipe. It's where you breathe in and breathe out. And so it's a tube that is really important to what we're going to see. And so I'm going to show you really briefly about what we're going to talk about in just a few seconds. But the trachea starts out as a large tube that carries air. And you're going to see that it's going to split off into a couple of main branches. And this is the left bronchus. Those first main branches are called the bronchus or the bronchi. One bronchus, two bronchi. And then they branch out even further. So you see them start to branch out even further. We call those the bronchioles like that. And then as the bronchioles get smaller and smaller and smaller and smaller, they'll come to the end and there'll be these little air sacs. We see these little air sacs like that. We call those the alveoli. They're air-filled sacs, obviously. That's why we call them air sacs. And they are where the gas exchange actually happens in our lungs. So that's the basics of it. We're also going to look in a few minutes at this little structure here called the diaphragm. I think most people know what that is, but we're going to see how the inhaling of air and exhaling of air, how the diaphragm will change and alter movements to allow the lungs to expand and to release. Um, so we'll be looking at that. And so this is just a picture of, you can see the end of the very small ends of the bronchiole. See how we call it the terminal bronchiole. It goes from being the windpipe, and at the very end it becomes a muscular piece. It goes smaller and smaller and smaller from the the bronchi to bronchioles to um, um, some smooth muscle that's still the bronchiole, and then to the air sac. And then you can see some of them, the air sacs, are covered with tiny little blood vessels that we talked about called capillaries. Capillaries are the smallest kind of blood vessels, and remember, capillary means hair, and so they're very, very hair-like structures, and they're covering each one of these alveoli, each one of these cells, and the air is exchanged. And so we're going to see we're going to see gas exchange in and out. So um, capillaries that are oxygen containing drop oxygen. They'll pick up oxygen, they'll become oxygenated, they go back to the heart to be pumped out to all the rest of the tissues. This blood that's blue, remember they're always shown as blue as being um, it's dark blood because it's not exposed to air, and it so they always show it as blue in pictures, and it will be deoxygenated blood, and so that came from the heart out through the pulmonary arteries out to the lungs, and it will exchange carbon dioxide back out, and out they go. And so it's the cycle of how we get blood, and then the oxygen-rich blood goes back to the heart. All right, so now that we've seen that, let's talk a little bit about the respiratory system. As we said, the gas exchange takes place in the lungs. We just saw how it takes place. Um, gas is exchanged from the alveoli directly into the bloodstream via the capillaries. And how we inhale it through our mouth or our nose, and we exhale it out through our mouth or our nose. And there's all the steps in between that we just talked about with the respiratory, with the trachea and moving down to the air sacs. We're going to see a little bit more about this in just a second. But really, think about the respiratory gas exchange being two functions, right? Two phases. One is to bring oxygen to the tissues, and we call that the internal exchange. And one is to eliminate carbon dioxide, and we call that the external exchange. And the external exchange is the one that's between the air we breathe, the atmosphere, and our blood. And so that happens in our lungs. The internal gas exchange is once those capillaries go back to the heart, pumps back through the left aorta, the left ventricle, back out through the aorta, the left atrium, the left ventricle, up through to the aorta, and out to our blood, out to be delivered to all our blood. Once it's out, this is where we start to see gas exchange happening. So that's between blood and tissues. And as the air enters the nose, we talked about it just a second ago, how the air came in through the nose, went past the sinus cavities where it gets warmed, it gets a little bit of, gets warmed up a little. It makes sure things stay, kind of moist, and off they go. Goes through the pharynx, and then the pharynx is going to be divided into those three regions, and the nasopharynx, oropharynx, and laryngopharynx. We just talked about all of those, why they're called what they're called, where they are within the entire pharynx region. The pharynx, and we talked about the larynx as well, how it's those little vocal cords that we see. that allow us to speak. And so the pharynx will, feed into the trachea, and the trachea is that cartilage kind of tube that eventually, as it gets smaller and smaller and smaller, through the bronchi, left and right bronchus, out to the bronchioles, and then out as it gets to the alveolar sacs, it gets replaced by smooth muscle. And so you can see this is just a pathway through the respiratory system that we see. So the nose, the nostrils, goes into the sinuses, goes into the pharynx, larynx, and then to the trachea, to the bronchi, to the bronchioles, and to the alveoli, where gas exchange occurs. It's important to know that the alveolar sacs contain air, but they also have the lung cells are also have some, it's almost a foamy, kind of soapy kind of um, substance that helps for gas exchange called a surfactant. And that allows those cells to be able to um, increase for lung expansion. So we are able to, breathe big and breathe small. And so surfactant helps our lungs to get larger and smaller. And we're going to see why that's important in just a second. And so this is just a little anterior and posterior view of sort of where we were looking at, just as a point of reference from what we saw before. Last week when we looked at glands, we saw the thyroid, right? And so we have some cartilage there. And then we have the epiglottis, that little, it was called it like a, a boxing, I can't even think of the word, the little thing. Oh, the little flap of cartilage there is the epiglottis. And then there's a nice bone, a hyoid bone that's right around our neck and our windpipe to help it stay intact. And so then we see the trachea behind it. And so this is all cartilage around it. And then inside is the trachea, right? So the lungs themselves, I don't think I took a picture of the lungs in here. No, just a picture. There's the word lungs. I was thinking about saying something else clearly. We have two lungs, typically. The right lung, your right lung, my right lung, not on a picture. The right lung is larger and has 3 lobes, and the left lung has 2. Like all things, the lungs have their own lining cells, right? And we also have the thoracic cavity that has its own lining cells. And in between those 2 lining cells is a little moist, kind of air-filled space that's very wet and kind of gooey. And so the two linings that I just talked about, one is called the parietal lining, or the pleura, the parietal pleura. That attaches, the lining is attached to the thoracic cavity itself, so it lines the thoracic cavity, whereas the viscera, or the visceral lining, covers the lungs. And in between, as I said, there's a tiny thin space between the parietal and visceral pleura that is really very small, and it just is moist, and it keeps those two linings from sticking together. But it also does other things too. But it's very, very moist in order to keep it functional. I think maybe I was going to put pictures of the lungs there and chose not to. I don't know why. Anyways, let's look at a couple of med terms associated with respiration. The suffix pnea, like dyspnea, is referring to breathing. So dyspnea was difficult or painful breathing, right? Oxia is referring to level of oxygen in the blood. Hypoxia is low blood. Capnia talks about where oxia refers to levels of oxygen, capnia refers to the levels of carbon dioxide. So hypocapnia. And phonia is referring to voice. So that makes sound that sounds like something that would be vocalized, right? So aphonia is a loss of voice, no voice, right? A is without. So aphonia, without a voice. Okay. Nase or naso, these are roots. Nase or naso is for the nose, of course. Rhine or rhino, if you've ever heard of rhinoplasty, a nose job, um, refers to the nose as well. Pharynge or pharyngeo is referring to the pharynx. Larynge, laryngeo is for the larynx. Tracheo is for the trachea. Broncho, bronchi, all refers to the bronchus. So bronchiole is referring to the bronchiole. It's not much of a root, is it? It's missing one letter. Phren or phreno is the diaphragm. We're going to talk about that. We talk about phrenic breathing, right? Or phrenic activity. It's talking about the diaphragm doing it. So if someone says, we're going to be practicing our phrenic breathing for singing, they're talking about managing and controlling the diaphragm. Phrenic or phrenico sounds similar, and they are. It's the nerve that's going to be involved in breathing as well with the diaphragm. So the phrenic nerve is going to, we'll see in a second, it's going to activate the diaphragm. Pleuro, this is an important one. Pleuro refers to that pleura that I just talked about, those especially the two pleura and the space in between. We see pleura or pleuro referred to that all the time. Pulmono always refers to the lung, and pneumono refers to the lung as well. Also refers to kind of air in the lung. So pneumothorax is air in the thorax. Spiro, we always talk about breathing. I'm trying to think, the only thing I can think of that spirometer is a breathing treatment, but I'm trying to think of another word where spiro is used. Maybe it'll pop to me. So those were the roots and the suffixes that are most commonly associated with lungs and breathing. I know people had trouble on their exam looking at words. Remember, you don't have to memorize every word. You have to learn the roots and the suffixes and the prefixes to help you learn. So I'm not going to sit and give you a list of roots and have you memorize that. You're trying to learn medical terminology, right? So be using those, though, to your advantage. So how does breathing actually happen? Well, breathing, or we call it pulmonary ventilation or ventilation, is a constant cycle of breathing in and breathing out, right? Inhaling, exhaling, inspiration of air, expiration of air. So it's a constant cycle. Sometimes we can control it ourselves. I think anyone, if you've ever tried, you can slow your breathing down. But typically it's controlled by your brain stem at the back of your brain, at the back and bottom of your brain. And it's autonomic. It doesn't require anything for us. When you're asleep, you're not actively thinking about breathing. And as I'm talking, I'm not actively thinking about breathing. What causes our breathing to change? It's actually drawn on the physiology of our body, and very specifically a couple of components. We're going to look at the pH, or the acidity or alkalinity of our body. Our breathing responds to that. And pH and the metabolic waste product carbon dioxide tend to go hand in hand. So if you have a lot of excess carbon dioxide, your pH is going to change as well. And so we're going to talk about those two conditions shortly when we're talking about respiratory alkalosis or acidosis. There are other reasons that our pH and our CO2 can change, and that's in our kidneys. It's actions or inactions in our kidneys. And so when you hear that, you may hear metabolic acidosis or alkalosis. That's different than respiratory. Respiratory means it's our breathing that's affecting it. And so those two systems, respiratory and metabolic, lungs and kidneys, they work together to maintain really this optimal level of pH, our blood acidity or alkalinity, between a very narrow range, a pH of 7.35 to 7.45. If it starts to stray to those outer limits of those two, your breathing is going to start to change. And your breathing can either speed up and you can have very rapid breathing. Anyone that runs or does exercises and you, right? Your body is trying to expire a lot of carbon dioxide out, a lot of metabolic waste. And if you are kind of long and slow breathing, you're trying to breathe in more oxygen and retain some of your carbon dioxide. And so it will change the pH. So your body will either change down to really slow breathing to try and keep more carbon dioxide in our body, and it actually will make your pH go down a little. So depends on what your breathing is. And so it really is controlled and adjusts to changes in those kinds of concentrations of things. So, but how does this work? So here we have a great picture here. And remember, the diaphragm was that little flap, that little the muscle right across your, kind of horizontally below your lungs. And what happens is I showed you that there was the word phren or phreno, right? Was referring also to breathing and related to the diaphragm. And so the phrenic nerve will stimulate the diaphragm to contract and to flatten up. And when that happens, our chest cavity enlarges and it allows our lungs to get larger. And it makes the air, as the lungs expand, air just gets sucked in. So and that's what happens. So if you breathe in really deeply, you feel yourself, your chest opens up, right? And then expiration, breathing muscles will relax, the diaphragm relaxes, lungs are allowed to move back to their normal size, and that will cause air to be expressed out of our lungs. And that goes on all day, every day, constantly. No stopping this. And so it's a relatively simple but kind of amazing process between the phrenic nerve stimulation of the diaphragm, and remember the stimulation comes from activity associated with the brainstem, stimulates the diaphragm to contract, flatten, allows your chest cavity to expand, and it draws air into your lungs, and then it goes in reverse. And so this is just a big picture of the same if you needed to see it. And so we've just breathed in air, right? What happens to it then? So we brought the air in, and remember those little capillaries that were covering our alveolar cells, our alveoli, those little air sacs, I should say, not cells so much, little air sacs in the lungs. Gas is exchanged from inside of the sac to the capillaries. The capillary brings blood back to the heart. Eventually, capillaries all feed into the pulmonary vein, which is going to bring blood back to the heart, comes in through the left atrium to the left ventricle, and then back out through the aorta to go to the rest of the body, right? But when that exchange of oxygen and carbon dioxide happens in the lungs, in the alveoli, oxygen is taken in our breath, and it binds to a component in our red blood cells called hemoglobin. Hemoglobin has iron in it, and it has structures that allow us to carry 4 molecules of oxygen for every molecule of hemoglobin that we have. And so it is it's a great oxygen carrier. And so what it does in the lungs, I'll say it briefly. So hemoglobin loves to carry oxygen on, but it likes carbon dioxide a lot more in a lot of ways. And so you have to be in a place where there's lots and lots of oxygen for carbon dioxide to sort of jump off the hemoglobin and to be replaced with oxygen. And so because your lungs are so filled with oxygen, right? The oxygen basically, I call it jumping on when I'm talking to my students. It binds to the hemoglobin inside of the red blood cells and it gets carried around, right? When your red blood cells carry through the bloodstream, goes out through the arteries, to the arterioles, to the capillaries, and gets to the tissues, all of a sudden you're in an area where there's considerably more carbon dioxide than in the lungs. So oxygen jumps off, and who jumps on? Carbon dioxide. Yep. And so off it goes. Oxygen that is picked up in the tissues, carbon dioxide that gets picked up in the tissues doesn't stay that way the whole time. It actually gets converted chemically and converted into something called carbonic acid. It's way too much to talk about in this class beyond that the book talked about, but it's part of the process that produces a more acidic blood. And so I just talked about how either you can accelerate or decelerate your breathing to adjust the pH to exactly where it's supposed to be. Sometimes that happens on purpose, but your body actually does most of this naturally. And so the gas transport is really just, if you have to think about it, oxygen is carried on hemoglobin to inside of a red blood cell to the tissues where it's exchanged for carbon dioxide, at which point as it's traveling back up to the heart, sorry, part of it will stay attached to red blood cells, and part of it will be converted to carbonic acid that actually will be inside the blood as a component by itself and changes the blood pH. All right. Some of the key terms, we're not going to go through all of them. So the adenoids, some people have their adenoids still, some people don't. They're a lymphoid tissue inside of the nasopharynx, and frequently you get them taken out, kids get them taken out with the same time as their tonsils. We talked about all of those. Compliance is, sounds fancy, doesn't it? It sounds so regulatory. I guess it is. Compliance is talking about how easily the lungs expand when that pressure is put on them. We'll talk about some respiratory disorders that reduce the amount of compliance that we have. But when we talked about that surfactant a minute ago, surfactant actually helps us to maintain compliance. The diaphragm is that muscle under the lungs that we just talked about. The epiglottis we talked about. Ooh, expectoration. This is, it's not just spitting up mucus, like if you have a cough or a cold and you have a little mucus. No, if you have an expectoration, you're actually coughing up sputum, which is deep down inside of your lungs. And it usually, they'll check it and they'll look quite often to see if there's a pathogen, a bacteria or something that is infecting your lungs. But expectoration is that act of coughing up not just mucus, but sputum. Let's see. The glottis is the space between the vocal cords. I didn't talk about that. The lingual tonsils is just the tonsils that I was talking about. So let's see. Lungs. Mediastinum I didn't talk about also. Mediastinum is the space between the lungs. Yeah, it's the mediastinum. Nose we talked about, oxygen. Palatine tonsils, it's another little bit of lymphoid tissue. Phrenic nerve, pleural space. We talked about that. Ventilation, sinuses, sputum, surfactant. Trachea. Turbinate bones are bones inside of the nose that help with smell. So let's look at some of the clinical conditions associated with respiration. Um, the things that we worry about the most are things that cause resistance to airflow, and they limit the proper expansion of our chest, that compliance issue, right? Things that typically we're going to talk about are things like an infection, some kind of an injury, um, allergies. If you've aspirated something, if something goes down into your lungs that you shouldn't be, like water, right? You've aspirated water, or any kind of a carcinoma, any kind of a tumor or cancer. Um, I talked briefly about changing in ventilation, that hyperventilation or hypoventilation. Alkalosis. So if you have, um, so if the amount of carbon dioxide and carbonic acid doesn't stay where it should be, kind of in that normal process of our breathing, typical breathing. I told you that the carbon dioxide creates carbonic acid. We convert it to carbonic acid, which that sounds like acid means it's a low pH, and so the reason that we get a low pH, so we have a low pH. There's a byproduct also that happens with the formation of carbonic acid that releases. I don't know. It's too much information. If people have taken biology or chemistry, you'll know this. It releases hydrogen ions in the process of converting the carbon dioxide to carbonic acid, and so the pH becomes lower. But if you hyperventilate, that rapid breathing sends too much carbon dioxide out of our body, and all those hydrogen ions are kind of being converted in this process in a different way, but your blood becomes too alkaline. If it's too slow, you have too much carbon dioxide in your blood and it becomes too acidic. All those secondary hydrogen ions keep it acidic. So that's for the real A&P nerds in the room, like me. So changes in the end. Hypoventilation means slow breathing. Hyper, fast breathing, right? And it just changed to alkalosis or acidosis of the body. And remember, if it's happening because of the lungs, it's respiratory. If that happens not because of breathing, the carbon dioxide carbonic acid can build up other places, not in the form of carbon dioxide, but carbonic acid with the kidneys. All right, let's just move on to some of the conditions. Pneumonia is caused by basically bacteria, right? It's typically caused by bacteria. There's lots of different kinds. We can get pneumonia all different places in our lungs. We can get them in the bronchi, the bronchioles. We can get them in the actual lobes of the lungs. And honestly, this is actually quite difficult. Pneumonia, it sounds like, oh, yes, pneumonia, right? No, especially in patients who are debilitated, people that are bedridden, people that don't have, um, good mobility, or they're in some way debilitated. It's actually quite difficult to have them. We're going to talk about RSV in just a second. Some of the common bacteria, we'll see things like a streptococcal infection, strep pneumoniae, or Haemophilus influenza. We've all heard of influenza, right? The flu. One is caused by a bacteria called Haemophilus. Klebsiella. We see that in patients as well. Your book had quite a few of them. Streptococcus pyogenes is scarlet fever. You may have heard that as well. So there's lots of different pneumonias, lots of different bacteria that can cause pneumonia. Something that's been on the rise the past maybe 2 or 3 years is RSV, respiratory syncytial virus. RSV it's been around for a long time, but I think post-COVID we've actually seen kind of an increase in RSV in especially very young children. And it causes inflammation in the bronchioles. It can cause pneumonia. Um, it can cause um, any kind of an infection in sort of the upper respiratory tract. So, everything sort of, um, um, like the bronchioles, right? Not in the lungs itself. Um, Really, the people that get most affected by this, we see it in very, very young kids, like, infants and young toddlers, where they don't really have a great um, immune system yet, but also patients that have kind of underlying disease, people with congenital heart disorders, immune disorders, whether it's HIV or someone who's gotten a transplant, exposed patients who are smokers. RSV becomes a real issue because it really affects breathing and ability to respirate properly. Couple of others really quickly that you probably heard about. Tuberculosis is caused by a bacteria called mycobacteria. It's Mycobacterium tuberculosis, exactly. And TB is, for a long time, was almost eradicated in the United States. We've definitely seen a comeback with this, and we've seen it with patients with HIV that have, kind of a reduced immune response, or, if they're in active AIDS stage, where they have immune deficiency, then they really don't have a great um, immune response against TB. So we've seen some of that going on. Also, the TB mycobacterium is becoming more and more resistant to drugs that we have available. So it's been a rough road with TB recently, maybe the last 20 years. Not good. Um, let's see. TB though is, and as a healthcare worker, you're going to be asked to watch this. It's fever. It's a weight loss for no known reason. A really kind of a deep cough. And hemopsis, which is a sputum that has blood in it. So all of those things can be things that people would be wanting to look for. Um, all of us as healthcare workers are asked to get one or the other kind of a TB test. One's called a MANTOUX test, MANTOUX. That's become a little bit less common. It's a subcutaneous injection that give you a little bit of little pieces, little pieces of the tuberculum organism, not the whole thing. So you can't get tuberculosis by getting a little MANTOUX test. We challenge the immune system with a tiny little piece of something that's not pathogenic, and then look and see if you have an immune response. If you have an immune response, it means you have um, been exposed to TB before, in the form of either the BCG vaccination, which we don't do in the United States routinely, or you've been exposed to someone with TB, or you've had TB, and then they're going to check you out more. Let's move on. Influenza is a flu virus, right? So it's a virus, so don't be asking your doctor for antibiotics for it if you have the flu. Um, Flu is it's a respiratory disease. We see, you know what it is: fever, chills, headaches, muscle aches, right? Cold and flu symptoms. Typically self-limiting, resolves by itself, except for when it's not. Very dangerous for older people, people who are immunocompromised, medically compromised, children. The flu is not to be taken lightly. So there's the reason that we get a flu shot every year. And if you work in healthcare, you're going to have a hard time not getting a flu shot. Um, the reason that we get a flu shot every year is it mutates very quickly. And so we don't tend to get the same flu every season. Croup is one that affects young children. Croup is different infections that it could be associated with, but really what you end up seeing, it could be, it could be RSV, it could be flu virus, it could be adenovirus, lots of different viruses causing croup, but it really is an upper respiratory infection that causes the airways to constrict or get smaller. And they call it a barking cough. It's like I can't make a sound. You can look it up and see if you look up croup. Um, Common cold is another virus. We often see it as a rhinovirus. Um, I think we all learned that quite a few of us. Some people got sick from COVID and some didn't. And some people were very surprised to see that a coronavirus, COVID is a coronavirus. It was a novel coronavirus. So the common cold is a type of coronavirus, but it's not COVID-19 coronavirus. Coronavirus is the family of viruses. So common cold, we know what it is, but often it's caused by the rhinovirus. This is probably they're all pretty common for the common cold. You know what it is, a little cough, a little cold, fever, the common cold. And we don't usually treat that. Couple of other things as we start to go through emphysema. Emphysema is from exposure to cigarette smoking or pollution if you live in a very polluted area, or if you have chronic lung infections. And what happens is it damages the alveoli and makes it so that they don't, you lose lung function. You lose lung tissue, and that means you lose the ability to breathe properly. So you end up with something called COPD, chronic obstructive pulmonary disease. Other things that we associate with emphysema are things like asthma, um, bronchitis, anything that is narrowing the ultimately narrowing or reducing the capacity of the lung tissue to be able to do what it needs to do. So lots of ways you can get emphysema, um, and then some of the affiliated diseases that are not caused by things like smoking or pollution, but have sort of a same kind of same kind of an issue in developing breathing issues. And so asthma, I just started to talk about, is narrowing of the bronchial tubes, and that's why someone's having an asthma attack and they take their inhaler. It opens the bronchial tubes. The rescue inhaler will work to open the bronchial tubes very quickly. Often caused by allergies and other kinds of diseases that cause the bronchial tubes to constrict or get small, or the linings get swollen, which effectively makes a smaller lumen of those hollow tubes, right? Inflammation, excess mucus accumulation, are all symptoms that can affect the disease process that can affect the patient's ability to breathe. And so you'll hear kind of a wheezing sound, dyspnea, they'll have difficulty breathing, they may even turn blue. So asthma, again, sounds like because we see them all the time, we talk about people with asthma all the time, people think it's nothing, but it is not nothing. Um, People can die from having an asthma attack if they don't get their medication. Um, and the best way to treat it is by, getting rid of the irritants. If it's some kind of an allergen, someone has allergies to dust or something, get rid of it. Or use that rescue inhaler, a bronchodilator, um, or or many asthmatics have a rescue inhaler for immediate use, and then every day they also take a steroid to try to reduce that inflammation process, and help to um, maintain effective breathing. Pneumo, um, pneumoconi, pneumo, pneumoconiosis. I have to say that. Don't say that 3 times fast. That's just talking about it's a chronic irritation and inflammation caused by dust particles. Often we see this in patients who have some kind of an irritant where they work. If they work with something like silica or coal or asbestos fibers, they get an irritation and inflammation that can affect their breathing. Typically, it's industrial based. I think we typically think of it as a sort of an industrial based disease. Lung cancer is obviously carcinoma. Lung carcinoma is cancer of the lungs. Cigarette smoking is very large, but we're starting to see a very high incidence of lifelong non-smokers getting getting a form of lung cancer as well, and it's very high. I think I was just reading about it in the last week or so. I want to say maybe it's the it's the sixth leading cause of you know cancer that's not related to smoking. Something I shouldn't even quote that fact. I don't know. Cancel. Um, it was pretty high. um, but lung cancer does not tend to have a great outcome because you need to be able to breathe. And so it's the leading cause of cancer-related deaths in men and women. It has been increasing over time, but now as I said, we're starting to see it from environmental factors, places with um, high degrees of air pollution, which is problematic. Um, the most common form is a squamous cell carcinoma, and the problem with lung cancer is, yes, it's killing off the cells in your lungs, but it metastasizes or goes other places really pretty easily. So it is that contributes to its pretty poor survival rate over a long term. Respiratory distress syndrome, RDS, we see this in newborns and infants, and it results from a lack of that surfactant, that soapy stuff that helps us to breathe appropriately and have that good compliance, right? And so we often see this, as I said, we see in little kids that are premature. And so actually, if someone is going into premature labor, they can give mom a drug, an injection, or in through a IV. I don't know whether there's an injection directly. It must be an IV that will actually help the infant's lungs to develop and be able to produce more of this surfactant inside of the lungs. And so if they can hold off premature birth for a couple of days and get the baby's lungs, the infant's lungs, developing this surfactant, it's a much higher degree of a higher improvement level for the baby at birth, even when they're premature. Um, let's see. Lots of things can cause respiratory distress besides just prematurity, trauma, allergic reactions, infections, but basically it causes an edema, a swelling that makes it so the infant doesn't live. They go into respiratory failure. You have to have this surfactant letting your lungs expand and contract. Cystic fibrosis is a genetic defect that's inherited, and it reduces something that helps us to change the way that chloride is taken around our body. And it causes the mucus that's associated with the respiratory system to get very, very thick. And so if you've ever seen anyone, with kind of home treatments, they'll sort of pound and make some pounding movements across the back that they're basically trying to manually break down the mucus in the lungs. And because it has this genetic defect, makes it so the chloride doesn't transport well. We can actually use something called a sweat test to help to diagnose it. And so it really is. They look at the amount of sweat and they measure it, and they look at the concentration of sodium and chloride in sweat. That's a very interesting test to look at. It's not treatable, but we can identify the presence of it. So they know where it is, and they know the gene, and they know DNA sequence that will identify it, but they haven't found a way to cure it yet. SIDS, or sudden infant death syndrome, is an unexplained death of an infant. Um, the infant goes to sleep and doesn't wake up. Doesn't show any real signs of it. They don't find any real pathology when they do the autopsy, and so it's just unknown. They do know there are things that you can do to minimize this. Um, Babies no longer sleep on their bellies when they're infants. They sleep on their back. It's tough once they learn how to roll over, but until then, keep them on their back. Don't smoke around a newborn. Use a flat mattress. No more putting the babies on, 57 pillows to make them all soft and fluffy. Nope, nice hard flat mattress. No pillows, nothing, and not too many blankets. Don't need to overheat the baby. Um, and so they have known for a while that these are factors that can contribute to SIDS. So any new parents are told to, avoid these things. A couple of other things, pleuritis or pleurisy, both the same thing. It's inflammation. Pleuritis or pleurisy is talking about inflammation of the pleura. Um, um, Mostly it's painful. It's an infection there, and the infection causes pain when you're breathing, and it makes it so the breathing is very ineffective and becomes very shallow, and so you don't get great inspiration or expiration, and it's very, very painful. And so we get stuff that's inside between the layers of the pleura, the viscera, and the pleural layers, and yeah, we get stuff accumulating there from the infection. And so there's a couple of them that we see. Pneumothorax is an accumulation of air and gas in between. Um, Atalaxia, or yeah, that's the disease. Um, it I can't say this. Atalexis is the collapse of a lung. Pleural effusions. Both basically they're accumulations of different things like infectious pus, white blood cells, bacteria, blood, or other fluids. And so if someone has those fluids, those pleural fluids that are there, there's the viscera. This is what I was talking about. This is great. Here is the viscera, the visceral lining, and here's the little teeny pleural space, right? And this is the external, the parietal pleura right here. And so it has that tiny, tiny, tiny little space, and you can see the lung is bound around, is covered by the visceral pleura, and the thoracic cavity is bound off by the parietal and lining it. And so you have a little fluid there, and that's very thin. And what they do is if they find that there's a lot of excess fluid there, they'll actually, the way they initially treat it is they'll take a syringe and they'll actually draw out some of that fluid to try and release the pressure and allow your lungs to be able to expand to capacity. How do we diagnose many of these things? I'm not going to go through all of them. You can take a look in the textbook a little bit more, but basically we're going to be doing things like looking at an X-ray of the chest, see if we see abnormalities there. Do we see a place where maybe TB is an interesting bacteria? Your body kind of walls it off, and so they can see if someone has had a former or they have an inactive TB. But they had gotten TB before. CT scans, MRIs, lung scans, all sorts of things. They can put a scope down your bronchia. They can look at that pleural fluid under a microscope and see what kinds of cells are there. ABGs, arterial blood gases, that's where we're looking for that pH change, and we're looking also to see how much oxygen and carbon dioxide there's there. And honestly, it's more complex than that. There's all kinds of oxygen oxygen plus something else that we can look at. Pulse oximetry, that's the thing they put on your finger. They call it a pulse ox, and it will test how oxygenated your blood is. And pulmonary function tests. Really, they're going to look and see using it like a spirometer to see how well you can exhale and if your lungs have the compliance that they need. Um, as I said, ABGs or blood gases look really at, it's a snapshot in time. They do an arterial blood draw and they'll measure how much carbon dioxide is there, how much oxygen is there, how much of this bicarbonate. Remember, we were talking about carbonic acid, one of the parts of the process. The kidneys will release in metabolic control of pH. One of the byproducts that your body releases is bicarbonate, just like baking soda, bicarbonate of soda, same thing. And it will change the pH of your blood. So we can measure not just the carbon dioxide that looks at the respiratory alkalosis or acidosis. We can look at the bicarbonate, call it the bicarbonate carbonic acid system. So we can look at how much bicarbonate is in your blood too. Carbon dioxide, lots of carbon dioxide. Remember, when it's traveling through your blood, carries along a bunch of hydrogen ions. Bicarbonate is very alkaline, so it makes your pH go up. And then we look at your blood pH and see if it's falling within that nice normal 7.35 to 7.45 range. I just talked about a pulse ox. You can see what that is. It looks for oxygen saturation, pulmonary function. I just talked about, we're looking at, kind of that ability for your blood to have compliance. Are you able to, at what level are you able to, your lungs operating? Are they functional at a functional level or not? Let's look at some of the key terms. Acidosis, acute respiratory distress syndrome is an edema. Acute rhinitis is obviously an inflammation of the nose, the nasal mucosa. Aspiration, asthma, atelectasis, I can't say it. I can say atelexemia, atelexasis. Sorry. Do your lungs inhale and exhale sufficiently? Atel or atello means imperfect. So if it's kind of poor functionality, you have this condition that you're not able to breathe all the way in and breathe all the way out. Let's see. Bronchiotasis is a dilation. Croup we talked about. Cyanosis is just blue discoloration from not breathing. Diphtheria. We didn't talk about diphtheria. Diphtheria is an upper respiratory tract infection that will cause the cells there kind of get stuck together and they form kind of a weird, difficult tissue or clumps of cells that make it difficult for you to breathe in the case of when you have a pathogenic infection. Just we've talked about before, emphysema we did, and empyema, PYE is always referring to pus. And so we're talking about pus in the plural states. Hemoptysis, that's PTYSIS, the P is silent. Hemoptysis, kind of blends together, is spitting. So it's spitting of blood from the mouth. Let's see. You may have heard of like DPT, diphtheria, pertussis, and tuberculosis. No, DPT, diphtheria, pertussis. I'm not going to guess what the T is right now. My head is too tired. Pertussis is just another. That's whooping cough. And so it is. You breathe in and it sounds like a whoop. It's like. Let's see. Pleurisy we talked about. Pneumothorax, RSD, tuberculosis. We talked about ABGs, lung scans, bronchoscope. I think we've talked about all of this. All right, these are enrichment terms, so we're not going to stop there. You can certainly look through the enrichment terms. It will not hurt you. These are if you're really feeling awesome about all the midterms that you're looking at. Let's just look at a couple of really quick ones. ABG are blood gases. AFB is it's a special test we do in the lab to see how the bacteria works with some special staining to help detect TB in the lungs. Let's find BCG is the Bacillus calmette-guerin vaccine. It's the one that's used in other countries for TB, vaccine against TB. And that will give you, if you or someone you know has received the BCG vaccine, don't get a MAN2 test. You're going to blow up like a balloon in your subcutaneous structure. Once every 5 or however many years, they'll do a chest x-ray to make sure that you don't have any active TB. BS you see in medical notes all the time for breath sounds. COPD, I told you what that was. CO2 is carbon dioxide. I think most people have heard of a CPAP machine. It makes it so that it maintains pressure in your lungs overnight so that you get good sleep and good breathing. So go through some of these abbreviations and become familiar with those. Also, they might refer to like RUL for right upper lobe, left upper lobe, right? Right lower, right middle lobe, whatever. All right. So what is the opposite of tachypnea? What do we think? Tachy, the opposite is Brady, right? Inspiration, inspire or expire, right? So expiration. And hypocapnia, or for that's low carbon dioxide, or hypercapnia, I suspect, right? Pneumothorax, the pneumothorax is what? The pneumothorax is when you got air or some kind of gas inside that pleural space, right? And bronchostenosis. Stenosis refers to, I don't know if you've ever heard of it, if you've heard of stenosis in a blood vessel. Arterial stenosis means narrowing. So the lumen gets smaller. And so bronchostenosis, if someone had an inflammation, they had a lot of mucus buildup like in CF, cystic fibrosis, they may get a bronchostenosis, narrowing of the bronchial tubes. Yep. Okay, and last thing is the health professions. Respiratory therapists and respiratory therapy technicians help evaluate and treat breathing disorders. And so really they look at their patients and they will do different kind of breathing treatments with them based on their diagnosis to help them with improved breathing, both in the short term and in the long term. Sometimes it involves using equipment like a nebulizer to help open the pathways of the bronchi, but it also can be just routine breathing exercises, or medications. Although a respiratory therapist wouldn't prescribe them, but medications may also help to change breathing patterns, and respiratory therapists could help measure that. The other thing they do is quite often they're the people that draw blood gases. And so a respiratory therapist comes from a 2 or 4 year college, and you have to go through licensing to do it. And that is it. As always, let me know if you have any questions.